Greetings, my name is Brad Monk. I'm a gynecologic oncologist from Phoenix, Arizona, professor of the University of Arizona, Creighton University, and part of the US Oncology Network. I'm coming to you today from the 2019 European Society of Medical Oncology, and I would like to share with you a very brief summary of the three first abstracts presented at the presidential session, and they were all ovarian cancer. And they were trying to address the frontline treatment of newly diagnosed ovarian cancer. Heretofore, the state of the art has been using bevacizumab as per GOG 218, as approved by the EMA and the FDA, adding bevacizumab at cycle 2 through cycles 2 through 6 of carboplatin paclitaxel, and then bevacizumab in maintenance. And then we pivoted in December 19th, 2019 in the US to adding olaparib in maintenance, preferentially, instead of bevacizumab in BRCA germline and somatic mutant carriers. And then at this meeting, we showed in 3 studies that there was activity of PARP inhibitors beyond BRCA. The first study, presented by Antonio Gonzalez Martin from Madrid, called the PRIMA study, showed that niraparib had activity not only in BRCA patients in frontline maintenance, but in non-BRCA patients, okay? And there was a really dramatic, I would say dramatic and unprecedented activity in the non-BRCA patients, but who had a homologous recombination repair deficiency molecular signature with a hazard ratio of 0.5. Very, very provocative, really unprecedented. So they had about 30% that were BRCA. Of course, it worked. We showed that with olaparib and SOLO-1. And now beyond BRCA HRD patients, it showed almost the same clinical activity in maintenance, again, in HRD positive patients. And even in non-HRD patients, there was still some clinical activity, and I hope that this would lead to a global approval of niraparib in maintenance, not only in BRCA, but beyond BRCA. The second study, presented by Robert Coleman, was called VELIA. Now, this is a new PARP inhibitor, veliparib, and it was started with chemotherapy and also extended in maintenance. And it also met its primary endpoint, okay? That when added with chemotherapy and in maintenance, there was an improvement in progression-free survival. And also there was a benefit not only in that ITT population, but also in the BRCA and HRD subset. So both of those studies, practice-changing, brought us a fourth PARP inhibitor in addition to niraparib, rucaparib, and olaparib, veliparib. And PRIMA and VELIA were published simultaneously in the New England Journal, practice-changing papers beyond BRCA in newly diagnosed advanced ovarian cancer. Now, I told you that bevacizumab has been the historical experience. Maybe we should add both together, again, frontline. And that study was called PAOLA-1. And that study was the third paper presented in the first presidential session at ESMO by Isabella Rey-Coquard from France. And it also showed that together there was an additive effect of bevacizumab and olaparib. So you start with bevacizumab with chemotherapy, and then it's in maintenance, and then you add olaparib in the maintenance phase. And again, obviously that helped in the BRCA patients, we knew that, but the combination also helped even better than PARP inhibitor alone if you would do cross-trial comparisons, with an opportunity to use now olaparib and bevacizumab in the HRD population. Interestingly though, in the non-HRD patients, bevacizumab didn't add anything. So I think it's an easy message. If you have a BRCA patient in frontline, newly diagnosed advanced ovarian cancer, use a PARP inhibitor in maintenance. We have level 1 evidence that olaparib works, niraparib works, and also bevacizumab and olaparib works, but maybe you don't need the bev. In HRD patients, an additional 20 to 30%, veliparib works, niraparib works, and you could even use the combination. And in the HRD negative patients, maybe either niraparib or bevacizumab. So we're trying to molecularly characterize the triage of newly diagnosed advanced ovarian cancer to PARP alone, PARP bev, or bev alone. Thank you. Please read these papers in the New England Journal, PRIMA, Antonio Gonzalez Martin, and VELIA, Robert Coleman. Thank you.